Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Hello, I'm Solange Peters from the Lausanne University Hospital in Lausanne, in Switzerland. I'd like to welcome you to this program titled Immunotherapy for Early-Stage Resectable Non-Small Cell Lung Cancer, Optimizing Multidisciplinary Management Today. Joining me today are two wonderful interprofessional colleagues that I will let themselves introduce.
My name is Vicky Sherry. I have a dual appointment as an oncology nurse practitioner. I specialize in thoracic malignancies at the Penn Medicine Abramson Cancer Center, and I'm also on the faculty at the University of Pennsylvania School of Nursing, where I teach undergraduate and graduate nurses.
Wonderful to have a nurse practitioner.
And I'm Alex Brunelli, a consultant thoracic surgeon and associate professor at University of Leeds in United Kingdom.
Thanks so much. So today we are going to share and discuss as much as possible with the practice changing messages that you'd like to share with you. We'd like to discuss our real-world experience regarding the role of immunotherapy in the current management of early-stage resectable non-small cell lung cancer. We'd like to look and discuss the considerations for the use of adjuvant as well as neoadjuvant therapies when selecting immunotherapy for the single individual patient. And of course, we need to discuss how to best implement immunotherapy-based strategies in the daily routine in the clinical practice and manage and monitor their side effects. A brief introduction about where we are. So we have been seeing a revolution in the fields of early stage immunotherapy treatments in the recent, I would say, 3 to 5 years, but more in the last 3 years, with maybe 3 definitions to keep in mind. You can deliver an adjuvant immunotherapy. We were used to deliver adjuvant chemotherapy for an important, significant, but 5% benefit survival long term. And you can also administer post-surgery, post-chemo, yes or not, you can administer adjuvant immunotherapy. You can also invert the sequence and administer neoadjuvant treatment. And we have been seeing one trial with neoadjuvant chemoimmunotherapy before surgery, surgery being the last step of this curative intent treatment. And what we will discuss a bit less today, because it's still not available, so it's still not in the practice and the daily routine, is what we call perioperative. It's the full package. It's the adjuvant part, but also the neoadjuvant part, meaning that immunotherapy will be delivered before and after surgery in all patients in this trial. So basically, we have 2 adjuvant trials to discuss today, very important one, using 2 different components of immunotherapy, pembrolizumab and atezolizumab, and 1 neoadjuvant chemo-IO trial using nivolumab. Therefore, let's briefly review the key clinical evidence for immunotherapy in the management of early-stage disease. So I will start with Alex to give us maybe a brief overview of the key data we have today from these 2 studies in the adjuvant setting.
Thank you very much, Solange. In the adjuvant space, we have 2 studies that led to the approval of atezolizumab and pembrolizumab in the adjuvant setting. The Empower 010, which is based on adjuvant atezolizumab following resection and platinum-based chemotherapy for stage 2 to 3A non-small cell lung cancer and PD-L1 expression greater than 1% in some country, but for instance, in Europe, greater than 50%. And the atezolizumab has shown in the Empower 010 an excellent hazard ratio in the PD-L1 expressed greater than 1% with a hazard ratio of 0.66. And especially in the population with an expression of greater than 50%, it showed the greatest benefit especially in the cohort excluding EGFR and ALK mutant, with a hazard ratio of 0.42 for overall survival in this subset. There has been also a subgroup analysis of the Empower 010, specifically for the population for which the atezolizumab is approved in Europe, so PD-L1 greater than 50% without EGFR and ALK mutation, stage 2 to 3A, and finding that the greatest benefit is mainly driven by lobectomy. Considering that this group is the largest group of the entire cohort, and in this lobectomy patient, the disease-free survival hazard ratio is 0.34, and the overall survival hazard ratio is 0.31. So very good results in the PEARL or Keynote 091 adjuvant pembrolizumab, also following adjuvant chemotherapy and resection. The disease-free survival in the overall population had a hazard ratio of 0.76. Surprisingly, in the study, the group of PD-L1 greater than 50% didn't show an added benefit compared to those with a PD-L1 greater or between 1 and 49%. So I think these are the most important data or findings from these two studies.
Thanks so much. We will have the opportunity to rediscuss together the selection of patients and biomarkers. But what is interesting is thinking about very similar settings, right? The approval in Europe has been very different. One in more than 50% PD-L1, the other one is in all comers. So it makes us really feel that it's more about the trial design and how the trial was conducted that really reflecting the science. It's quite important to really observe two things. First of all, the data are very similar. So the trial shows the exact shape of the curve, same shape of the curve, even if the numbers speak slightly differently. But more importantly, it's good to see that we have more than one treatment option because the availability might be different from one country to the other one. So at least we can offer that to the patient. And it's based on what we had with chemotherapy. The progress here is probably way higher than what we had in the past with adjuvant chemotherapy. So it's really something about offering new opportunities in addition to chemo. Interestingly, let's keep in mind that in the Empower 10, chemotherapy was mandatory. And in the PEARL trial, it was optional. And it's interesting because in the PEARLs, it doesn't look like the patients who did not receive chemo were really doing differently. But basically, it's something to keep in mind, right? This is the two adjuvant trials. Surgeons, you will let us know later on, think that adjuvant trials are always important because you will always have patients needing adjuvant treatment only because you discover the stage during surgery or because things were so fast, then you have only the adjuvant step 2 to improve the outcome. But you also had one key neoadjuvant trial, the Checkmate 816. It's key because it will probably be the only one, which is only neoadjuvant, meaning that the last step again of the standard treatment is surgery. Do you want to tell us a bit about it, Alex?
Yeah, so the Checkmate 816 obviously has revolutionized the neoadjuvant space. It is the combination of neoadjuvant nivolumab with platinum doublet chemotherapy for resectable non-small cell lung cancer, so with no distinction of a PD-L1 expression, or in other countries in Europe with PD-L1 greater than 1%, providing that obviously EGFR and ALK are not altered. And this is offered for stage 1B to 3A. The main data of the Checkmate 816, event-free survival and overall survival 3-year update. For the event-free survival, the hazard ratio in the all-comers was 0.68. A similar hazard ratio for overall survival, 0.62. Obviously, in the population with a PD-L1 greater than 1%, there is the greatest benefit. The pathologic complete response in this group was 32% in the Nivo group versus 2% in the chemotherapy. And the hazard ratio for overall survival was 0.37, which is very, very good. I think these results have or will be confirmed now with the 4-year survival figures
Yeah,
presented at this meeting.
yeah. The 4-year survival are shown at this ASCO meeting and really confirm, right? As you said, it's a revolution because we are probably learning that immunotherapy has a magnitude of benefit which might be increased when you decide to give it in a patient who is fit, in a tumor which is clonal, and in the presence of the tumor, meaning in the neoadjuvant setting. And it's a learning from melanoma already. They have shown it, and now we learn in lung cancers that might be the biologically appropriate way to move, but sometimes not always matching the circumstances of a hospital, of a health system, or of a single patient who arrives at the emergency room. So maybe now the next step is to deep dive into how to select, therefore, and how to select not only the patient, but the appropriate adjuvant versus neoadjuvant. What do we need to know? And Alex, the first thing I'd like to ask, because it's not trivial, is what you have this patient with initial diagnosis of lung cancer, you want to give neoadjuvant or adjuvant. What are these biomarkers that you need to test before you make the decision? Let's be careful now, you can still have ALK, EGFR. So what do you do in your institution to make sure that the patient journey is correct? What do you need to test in the biopsy?
So this is critical. All patients are discussed in the tumor board. All patients, regardless stage. It is important that all specialists are on the same page and discuss the patient. And testing has become crucial, of course, to drive decision making. When we identify a patient that potentially could be eligible for the neoadjuvant pathway, we obviously request molecular testing at least for EGFR, ALK, and PD-L1. Although PD-L1 is not a prerequisite for neoadjuvant, we still request it. And this needs to be done upfront on the biopsy tissue, obviously.
Thanks so much. There's one thing which becomes more and more important is the testing for mutation. You might ask, well, you can also test later on in the tumor samples, the specimen. The answer is no, because now we have better things to propose, better options to propose for these patients with an EGFR mutated non-small cell lung cancer or an ALK rearranged, because the adjuvant alectinib for ALK or osimertinib for EGFR are amazing treatment options, the best we have. So we are not supposed to endanger their administration in the adjuvant setting by giving preoperative in a neoadjuvant immunotherapy. Remember, they do not match very well. If you give immunotherapy and then osimertinib, you have one patient out of 3 who will probably present with an inflammatory lung disease and a kind of pneumonitis, the way you want to call it. So basically, you need to define at baseline what will be your patient journey and not improvising it later on down the road by acquiring the data later. So I think it's very important. It has become a tumor board mandatory parameter, right? You need to know the biology of the disease. But maybe the key questions that we can debate for hours in advisory boards is how to choose between adjuvant and neoadjuvant, how to convince about a certain sequence which might be a little unusual, right? Neoadjuvant is not very usual in many countries. How do you do to change the paradigm, Alex, in your centers?
You're perfectly right. I think it's more a habit. You clearly see resistance, especially from surgeons, to offer these strategies for inpatient in stages that are traditionally being considered, surgical staging patients up front. Large tumors without evident lymph nodes or N1 disease. It is clear from the trials, and it is clear also from the initial real-world data that these patients benefit from neoadjuvant treatment. There is a rationale, of course, to administer neoadjuvant instead of adjuvant, and there is a growing body of literature showing increased immunocompetence of T lymphocyte in the presence of the tumor, which obviously would increase the efficacy of immunotherapy in this context. And hence, I would say, obviously, there are exceptions, like patients with actionable genetic alteration, of course, for whom we have very effective targeted treatments. patients who have contraindication to immunotherapy, so we cannot offer immunotherapy. But otherwise, and it is I think the responsibility of the surgeons to embrace this new concept and to, I don't know, lower barriers.
Yeah, you bring something very, very interesting because it comes from a surgeon, right? So how did the role of the surgeon evolve? You need to convince your colleagues that the first step is not surgery, right? And that it's also by nature collaborative, because you have a patient, you don't want the patient to disappear. So it's something about from A to Z to collaborate and to make sure that the decisions are taken in common and in a consensus. So it has completely changed, right? I remember when I was a young doctor, the surgeon had always a decision in their hands, right? As the first and the last also. And now it's something like more a group decision.
Yeah, correct. I totally agree. The surgeon is the key individual. You don't have to convince the other members of the MDT, the oncologist, that this treatment is effective. But the surgeons, there are also some beliefs that neoadjuvant treatment with immunotherapy increase complexity of surgery, so there is resistance. I want to stress the very complex subject of resectability, which is also a crucial topic in the tumor board, because of course, this is up to the surgeon to decide whether the tumor is resectable or not. And if not resectable, then the patient is not for neoadjuvant treatment. This is something that at the current stage need to be clear. Neoadjuvant chemoimmuno is not for downstaging patients who are not resectable, but only for resectable patients. The MDT agreed that the patient is eligible. The patient goes and see the surgeon first, because then the surgeon will discuss with the patient risk and benefit of surgery and may even decide together with the patient that they are not an appropriate surgical candidate. And at that stage, if the patient has already started the discussion with the oncologist of neoadjuvant chemotherapy, that creates additional confusion and we have to start all over again. But I think it is important that when the MDT, decide collegially that a patient is a candidate, potential candidate for neoadjuvant, they should go and see the surgeon first, and then obviously the oncologist to discuss the neoadjuvant phase.
You stress something very important is probably this role of course, the surgeon plus the tumor board, because many surgeons think that it's time to address immunotherapy for marginally resectable. That's not what the trials tell you. Trials tell you that in this patient with an at diagnosis resectable and completely resectable tumor, they benefit, not the ones who are not resectable at baseline. So we shouldn't extend your knowledge to something which is just a feeling, an impression, an opinion. We do evidence-based medicine, right? And the other thing is, remember that radiochemotherapy followed by immunotherapy is still a very good standard of care and probably way better for this patient who have inoperable tumors, and even for many of these who have marginally resectable tumors. So let's remember that at the tumor board there are more than one options, and we have to consider all of these for the best of the patient. Either just to complete this part of neoadjuvant and adjuvant trials, is there any biomarker, I'm thinking about clinical or pathological biomarker, like the quality of response, pathological response being complete, or what we call major pathological response, or any, I would say, practical use of circulating tumor DNA, measurement of the tumor in the blood? Is there anything that you would need to advise people to look at or to take into consideration today, or you think it's a little too early and it's something just to follow in research? So any additional message in your practice guidance to give to the people listening to us?
Perhaps the pathologic complete response is still the most, let's say, accurate biomarker in determining survival. And this is clear from all the trials. Obviously, we are all waiting for more results or finding data about circulating tumor DNA. I think that would be important at some point to select patients for, especially when the perioperative treatments, will be approved. Should we give, the postoperative or adjuvant immunotherapy to everyone or to selected patients. So there are initial data showing that patients with clearance of ctDNA have a better prognosis. This is associated with increased complete pathologic response, but it's still not completely there, to drive clinical practice.
Thanks so much for this wonderful overview. But now we'll switch to focus on how we can best and better optimize the management of immunotherapy delivery and all the immunotherapy-based regimen in the clinic. So maybe, Vicky, it's really your, I would say, specialty. A point of concern. Some patients have a very complex journey, and for many reasons, what we observe in clinical trials is some of these patients who are supposed to receive a treatment to be cured never get to surgery. So the question is, they might be lost in their ways, they might be not sufficiently advised about how to perform, tolerate, manage the side effects. So it's quite worrisome for us to see that sometimes our strategy fails, and fails in a context where we were hoping for better than that. And what are maybe the considerations that the nurses can put in place or have in mind or remind us in order that the stakeholders can ensure the continuity of care?
So nurse navigators play a key role here. They're usually the point of contact, the first point of contact that a patient has with the health system. They're able to organize appointments, sometimes on the same day, making it more convenient for the patients, hence a better quality of life. Also, we talked about tumor boards. I encourage nurses to get involved with the tumor boards too. It's a great platform to have a voice. And although, yes, it's very important to know what treatment the patient will be getting, it's also important to know, can this patient get to treatment? Are there social determinants of health that will, delay treatment, or the patient won't be able to make it to treatment? So definitely get involved with tumor boards, and also communication. So we now have, it's not just they go to surgery and they come to medical oncology, it's now surgery, oncology, radiation, and I feel like they're all back and forth. And when we communicate, we need to communicate with the entire team. So there's so many times that I get a message from a surgeon or from a radiation oncologist or just from a medical oncologist, and it just comes to me, but it has to go to the whole team. We have to incorporate everyone so that everyone's on the same page, so that these patients can get through treatment and they get to their appointments, they have these appointments, and they can be successful.
We sometimes make the mistake of relying on the patients. What you have as a doctor, me, medical oncologist, for example, I indicate to the patient the whole flow of things, right? And I'm convinced that my job is done, the patient has everything in hands. But it's so much data. You speak about cancer, prognosis, immunotherapy, chemotherapy, and then a list of appointments, that my feeling is that we overestimate what any human being can accumulate or maybe digest in a single consultation, right? Do you agree with me?
Oh, absolutely. And another thing that's helpful is printing out calendars for the patient so they have their appointments right in front of them. It's, again, very simple, but it really can change, how they view things and them getting to these appointments on time.
It's really about having a centralization of this data around the tumor board, right? What we sometimes experience in our centers is the patient receives an appointment from the radiation, one from so suddenly it's kind of, and they overlap sometimes.
Yes.
So it's really about trying to make a single point of communication about these practicalities, right?
Yes, absolutely.
Yeah. So the most important, I would say, topic that was completely taken by nurses now, at least in many environments, is how to facilitate the management of side effects. Because you'd like to say the patient call me at any kind of specific events, or because it's immunotherapy, we are frightened. But there are also a lot of self-management. The patient can navigate the symptoms, sometimes alone or sometimes with your help. What did you put in place for the management of immunotherapy toxicity, immune-related adverse event, as we said?
So I think you'll agree, as well as Dr. Brunelli, that we have a pretty high comfort level now with managing immune-related adverse events. And if we don't, I always refer, or if I don't, I refer to the NCCN guidelines. But more importantly, it's telling our patients to report these symptoms. So I always say, today's your baseline. Any symptoms beyond, change from today, you need to report that right away. And it can get really convoluted with our patients who have lung cancer. They come in with a cough, they come in with shortness of breath. So It's today is your baseline. If your cough gets worse, if your shortness of breath gets worse, if you develop a rash, joint pain, anything, you let us know right away. Let us triage that for you. Don't sit at home and be in the midst of these symptoms trying to manage it yourself. So it's really telling the patients to report these symptoms right away, giving them contact information, numbers to call, and the sooner they report them, the faster we can treat them, and then possibly, if it's safe and appropriate, to get them back onto treatment.
Does it take you a long time? Because it's all of a kind of incentive, but also a kind of education that you have to do each single patient coming receiving immunotherapy. It's something that, do they go out with some guide or something they can read again at home? How long does it take you? It must be kind of, it's something, right? It's so important and it's quite complex. For us, it's simple, but not for a patient.
It's time consuming too. So I usually block a good hour of my clinic time just to go do patient education alone. I do give them handouts to go home with. I also print it out in their EMR so they can refer to it even on their phone, which can be convenient.
Oh, nice. Yeah.
And I come from a very large institution, so I have triage nurses, clinic nurses, PharmDs at my disposal as part of the team who can check in with these patients also. And then, so I'm very fortunate with that, but you know, we do rely heavily on the patients. We educate them and we expect them to take it all in. We also require usually someone to come with them on their first appointment to be a second set of eyes and ears.
To make sure
Take
that the
notes.
things are.
Yes.
Yeah, absolutely. Yeah.
Yes.
Wonderful. You really stress something which is extremely important, is to put in place before anything the communication within the team. It's a tumor board, and it's also in each service interprofessional communication to make sure that everyone has understood all the problems or positive factors about the patient in a due time, right? It's
Yes.
quite, yeah.
Absolutely.
Thanks so much. So maybe I think we have a good perspective about the data and about how we could optimize our care in Europe, because I think you're far more advanced than many centers in Europe in terms of having this interprofessional collaboration around the patients. But I think we have a kind of a good overview about this adjuvant and neoadjuvant treatments in terms of data and management. So the interesting thing at the conclusion is, I wouldn't say the best is still to come, but more complexity is to come for sure. Because we have been already seeing the data of 3 perioperative trials, meaning, as I said before, the full package, the full pack. So the neoadjuvant chemoimmunotherapy followed most of the time by 1 year of immunotherapy. So around surgery, it's a long treatment. It's 3 months before, it's 1 year after. So it's really something longer with a lot of immunotherapy. Of course, putting the patient at an increased risk of developing immunotherapy toxicity in a curative intent context. So nobody should suffer or have any handicap from that. So we've been seeing the AGENT trial, which is durvalumab before and after, the Keynote 671, which is pembrolizumab before and after, the CheckMate 770, which is nivolumab before and after. And we are still waiting for the atezolizumab equivalent. It's called Empower 30. And we have been seeing some trials mainly run in Asia, one with tislelizumab, the rational 315, but really done probably in an environment slightly different. But all these trials, they are redundant, that's the law of the market, but they show the same thing. There's a huge benefit of giving probably a bit more of immunotherapy. The main question we have with the field is it for all patients? Or maybe like Alex was telling, in this patient with pathological complete response, do they all really deserve an additional year of immunotherapy? In this patient with circulating tumor DNA negative, maybe once we'll have better tests, do we all really need 1 more year of immunotherapy? In this patient with stage 2 disease, and so on and so forth. But all of this, we don't have the answer. So how to decide today? I think, first of all, we need to keep a scientific open mind. Nobody is right, nobody is wrong. Having access to immunotherapy in early disease is a privilege and a benefit that we have been giving to our patients. We spend hours discussing in the corridors to know how much, how long is needed. I'm sure the future will let us know what is the best strategy, but we stay tuned to see all this data developing over time, seeing the follow-up increasing and identifying this patient who need more escalation and who potentially need a little less than this clinical trial. So I think it's amazing how much it moved from chemo to all of these opportunities of neoadjuvant, adjuvant, or what we really call perioperative. So I'm looking forward to learn more with all of you. So thanks so much. I'd like to thank you both, Vicky
Thank you.
And Alex, for this great discussion. I think it was very comprehensive. And of course, I'd like to thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you all for your great attention.
This program was presented by Medscape Education Global.